Hello, we have a great club webinar tonight for you. We have two things we're going to talk about. Even though in one of our webinars we talked about cardiovascular system and caths a little bit, kind of highlighted that. There were some more questions about the actual CPT codes, so I dug around in some of the presentations that I got to go visit and lectures I got to go see, and I think I got it broken down really well so that it'll be a little bit easier to understand those catheterization codes. And then CCO is working on a new project, which is taking a lot of real cases, real encounters for patients, redacting them, and then turning them into case studies. So I've got one of those, and our intern Tiffany worked on it and set it up real nice and pretty. It's formatted great, and she wrote a fabulous rationale. So we're going to look at that for risk adjustment, how we would code that for risk adjustment. And it's going to be fun. So first, let's talk about cardiac caths. And that is just some highlights on the CPT codes that go along with cardio catheterizations. And then this particular case for risk adjustment was an infectious disease case, so that was kind of exciting. So what do we do with a cardiac cath? It's very important that you understand how the procedure is done, because if you don't understand the steps that are involved, then you're not going to get anywhere. There is a lot of codes, but they're repetitious. You use them again and again and again, and they have very specific meanings, but the verbiage and the terminology is kind of intense. But once you understand that, then you're not going to have any problems with it at all. So let's talk about what is really included in doing the procedure of a cardiac cath. When you look at the codes themselves, you're going to see that they're going to mention the introduction, okay, and that's really them putting the needle in to wherever the access point is, what position they use, if they need to reposition something as they go, and the removal of the catheter itself. Also, a term that you'll see again and again is the mapping. They map out with an angiography, and you can go in and put angiography in Google Images, and you'll get those black and white images that look like, usually like a circle X-ray, and it will show the vascular system because they will have put contrast in. And then a lot of times you can see the catheter and the wires going up into the vessels and stuff. So mapping it out, how they go into what vascular families that they go into. They also do the mapping for placing the caths and doing injections. When they do this, they do imaging supervision. That's actually part of radiology. So they're literally doing like a live X-ray at the time. They put the contrast in so they can see the vessels. It looks like a Halloween tree, with no leaves. So they'll map it. They'll look where the catheter's going, which way. Are we going to go in this branch? Or are we going to go in that branch? Then the injections that they put in, supervising the radiological aspect of it, interpreting what they're doing and what they're seeing, and the report that'll be written. Now, another thing that they do with cardiac caths that I think a lot of people don't think about, at least it was never on the top of my mind, because when I think of a cardiac cath, I think, oh, they're going in to see if there's blockage, and if there's blockage, then they're going to just go ahead and, take care of that blockage, whether they roto-rooter it out or they put a little stent in, whatever. But for the most part, one of the things they do is they measure the cardiac output. Right, so they go up and get like into the ventricles and the atrium too, the heart, and then they wait and get the pressure from the blood flow going in and out through the valves, because that just studying that alone will tell them a lot about what's happening with the vascularization of the body and how it's affecting the heart. Another thing that I think I mentioned was the contrast injection. They do an imaging for that, and there's a different access site usually for that. But when they do contrast injection imaging for when they pull out the catheter and get done, there's a closure device there to seal off that access point. You know, it used to that the patient had to lay still for a very long time to let that, you know, so they didn't bleed out. But now they've got other devices that they use to kind of cap that vessel off, and it's kind of exciting to see. And I think it's down to like 2 to 4 hours. And then the final evaluation and report. All of this is encompassed in what they're doing with the codes. So we need to look at the codes themselves. Be aware that all of these codes that we're talking about are going to get a modifier 26, except if it's a Swan-Ganz. Now, Swan-Ganz is a little bit different, and that's another whole lecture. We'll talk about that another time. So modifier 26 is going to be used again and again. The very first code, the first CPT code that we need to mention is 93451. That's for a right heart catheterization. Now, in a previous lecture, I think I told you that it depends. If you go in through a vein, then it's you know, one particular heart catheterization, and if you go in through an artery, it's another. Now, off the top of my head, I cannot remember which one's which, so I have to go back and think about it again because it's not something I do all the time, but it is something you need to memorize. If so, just going off the top of my head, don't, you know, take this with a grain of salt. But let's say that if we do we go in through an artery, then it's always going to be a right heart cath. So if we go in through a vein, it would always be a left heart cath. Okay, I think that's right, but I could be wrong. It could be the opposite. That would be a great thing for you to go check out, but you need to make a note of that. And again, we did that in a previous lecture, and for some reason, I just can't remember it off the top of my head. 93451, that's the right heart cath. All right, then the rest of the code range that we're going to be looking at is 93452 through 93461. And in this code range, all of those codes from 52 to 61, be aware that it's going to encompass and include the contrast injection, the supervision, the interpretation, the reporting, and that is going to all be for anything other than if the patient has CHD. Okay, so again, the bulk of what we're dealing with is the code range 93452 through 93461, and it's really actually not a lot of codes. But when you start out, make sure you know they automatically include these things. So when you go and you look at that, you see that in the report, that's all kind of fodder. You don't have to pay attention because it automatically includes that stuff, right? You don't have to use additional codes for it. So that should make you feel a lot better when you look at the terminology. At least it puts my mind at ease. I think, oh, okay, this is you just alleviated my mind. Okay, now let's look at a left heart cath. Okay, that's going to be 93452. If it's a left heart cath, then boom, that's all you got to code for. If it's a right heart cath, right, we already looked at that code. Let's say they go in and they do a left heart cath and a right heart cath. That's going to be very simple, 93453. You get to code for both. If they go in to do a left heart cath and they puncture the septum and go into the other side of the heart, right, and then do some measurements, then you get to use a 93453. You get to code for both of them, even though it's just started out as one, and then they decide to go ahead and do the other. Right, that was something I learned from that fabulous lecture in DC at the regional conference for the AAPC. What if we're just going to do a coronary angiogram? Then very simple, 93454. Right, so if we do a coronary angiogram, 93454. Then let's add some other components. For 93455, we do an angio coronary angiogram, right? And we do a bypass graft, right? And from this point on, we're going to call that a BPG, right? So now we do coronary angiogram plus BPG 93455. So far with me? You know, it's really quite easy when you look. You can make yourself a little cheat sheet off of this. 93456, coronary angiogram, and a right heart cath. Right? Very simple. Right? Because all that other stuff we saw on the previous slide, that's all included, and that'll all be reported. But really, all you have to know is, did they do a coronary angiogram? Yes. Did they do a right heart cath? Okay, then our code is 93456. If they do the coronary angiogram, they do a, oh, actually, that's supposed to be a PBG, bypass graft. I inverted those. I apologize. And a right heart cath. Right? So we're doing the bypass graft and a right heart cath and the coronary angiogram. Then we're going to use 93457. So left heart cath, we have one code. We have one code if we do a left and a right heart cath. We have one code for an coronary angiogram, but we can do other things with the coronary angiogram. And if we do, then we have additional codes that we can use, right? So you wouldn't use 93454 and 93451. You would use 93456 because that's a coronary angiogram and a right heart cath. Okay, makes sense so far. Now let's talk about left heart caths. If we're going to do a left heart cath, then we have 93458, but if you do it of the native coronary, you do a native coronary angiogram. So what does a native coronary angiogram mean? They're going to do an angiogram of a vessel that hasn't been changed or altered by somebody else. It's just the vascular system that you were born with, right? So that's what native means. It's what you had going in, right? But if you do an angiograph of a one that has had a bypass graft, that's different, right? That's not a native vessel. So 93459, left heart cath. Then we're going to do a coronary angiogram plus the BPG. Simple. All right, now we're going to do 93460. So we're going to do a left heart cath, a right heart cath, and a coronary angiogram. And then last, we get to wrap it up, and it's kind of doing everything you could possibly do. 93461 is going to be left heart cath, right heart cath. We did a coronary angiogram and a BPG. Right? It looks so simple when you look at it this way. Now, what I would urge you to do is when you go in and do the BAT technique to your CPT manuals and you're looking at these codes, then you can come back, look at the slide deck and pay attention to, like, okay, now I'm grouping in 93458 through 93461. What do they all have in common? Well, they're all left heart caths and they're all going to be doing an angiogram, but the angiogram may be different. And then with 60 and 61, we're doing left heart cath and a right heart cath. And that means we're going into the left side of the heart and the right side of the heart, if you don't know. If you don't understand any of this terminology, if there's any component of this that you don't understand, then you need to go out and do some research on your own. And I would advise you, for example, go and do a Google image of a coronary angiogram, and then it'll show you what that looks like. I would also urge you to go out to YouTube because there's some fabulous sites out there that actually show them doing the procedure, and then they'll talk you through it, and they'll say, okay, now we're going in and doing our left heart cath. We decided now we need to go ahead and do a right heart cath. You know, and we're doing a coronary angiogram. So when you see it, then when you go to code it and you're reading the report, then you can almost see that video in your head. I'm a very visual learner, and a lot of people are. And then it makes sense. It's like, okay, it's step by step. It's really, but when you read the description, it's got all that other fodder, right? It says, okay, the interpretation, the contrast, da 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 da. But you don't need to know that because all that's already included in every one of these codes in that code range. You just need to know, is it a left heart cath with a coronary angiogram from a native vessel? That's all you got to abstract out, right? So again, when you bubble and highlight and annotate and do your BAT technique to your CPT manuals, make some notes off to the side, and you can maybe group these a little bit more in depth. This may be something that you really, really enjoy doing. In the future, we're going to have, in the very near future, we will have some of these documented, the reports themselves, and we'll walk through them, kind of abstract how we're going with them, and show you the difference in these codes, and we'll pull this back out so that you can see how simple it is. Yeah, all that other stuff's included, so we don't have to read that. We already know that's included. All we have to know is, did they do a right heart cath and a left heart cath, and what else did they do? Right, so it gets very, very exciting. Any questions so far as we go through that? No? Okay, we have a coding scenario now that I want to show you. I'm going to bring that case study over. We're going to have more and more of these. We're working on them now, and it's so exciting. This particular patient we have named Billy Blue. We like to use names of colors, at least I do. So let me clean this up and make this a little bit easier to see. I'm going to make it bigger for us. We'll give Boyd a chance to be able to see that as well. There we go. And I'm going to make this, let's zoom in to about 150. I think that'll be perfect for us. So we're going to go ahead and read this particular case as if, all right, we're looking at it for risk adjustment. It's been a while I haven't talked about risk adjustment, and that's one thing I really, really enjoy. So our intern Tiffany put this together from some cases that we were given. She redacted it for us, and we're moving forward. We're going to go have a lot of these. Hold on just a second. Okay, I'm back. Sorry about that. Okay, so my new office doesn't have a door that locks. Not so good when you have lots of kids in the house. All right, let's see here. Get back on track. So this has been redacted, and this is a infectious disease visit. That's something you probably are not seeing very often. You know, you don't think of infectious disease visits. So here we go. We don't care about the date of visit, except for when we're doing risk adjustment. We do need to verify that there is a legible date of service, and we do have that. Now, we also need to make sure that we have a valid doctor, provider, and this is an MD, Dr. Holmes, and so that is valid. Then our patient's name. Of course, you will usually have a list to correlate and make sure that it is the patient that you want. The patient's date of birth has to be on there. Now, as far as gender and age and stuff like that, we don't worry about that. But the primary care physician is Dr. Feelgood. So now we know that our patient, Mr. Blue, his PCP is Dr. Feelgood, but the provider that's writing this report is Dr. Holmes. And so Dr. Holmes will be the one that actually signs this particular procedure. Okay, now we cannot code with risk adjustment from the nurse's notes, but we can use the nurse's notes to validate some of the diagnoses that we have. So let's go ahead and look at that. patients here for a follow-up for a right foot osteo, which they abbreviated it, and we just happen to know, I happen to know that it's osteomyelitis, and if you didn't know, it's right here. Why is the patient being seen? Patient present with osteomyelitis. He just finished IV antibiotics, denies fever, chills, nausea, rash, reports constipation, says last BM was last Friday. Okay, so again, nothing there that we can code from because it's the nurse's note, right? That is not a provider that we're able to document off of. Now, another thing that I like to do when I do risk adjustment is once you have verified that your provider is there, your data service, the patient's date of birth and name is valid, then I usually go ahead and go to the very bottom of the chart. This is for risk adjustment. Again, so we're going to go ahead and look down here, and I want to see the electronic signature, because if it is not a valid electronic signature, you're more or less lost. There, you won't be able to capture anything from this documentation. So Dr. Holmes is our provider that signed this, and it does say it's electronically signed. There are all different ways to do this, and if you get into risk adjustment, you'll be seeing tons of different EMRs, and they may say authenticated by, verified by, but you want to be careful of viewed by, because if it's electronically viewed, that's not signed, right? So we know we have a valid signature, and the provider's credential is there. The company that I worked for, everybody's risk adjustment, depending on who you're working for, has a few little wonky rules, you know, that they may have. The electronic signature for the company that I worked for didn't require that it had their credential in it if the credential was stated somewhere else on that encounter. And so we know from the top that if it didn't say that it might have just said Dr. Holmes electronic signature, we knew that Dr. Holmes was an MD and he is a valid provider for us to be able to document off of, because it's stated here. They even accepted if the credential was found on the timestamp that was from the fax timestamp. So that's kind of cool. Okay, so now we've moved past the nurse's notes, and we're going back to the date of service, which of course the date of the visit was there. And is the patient a smoker? You're going to see that almost always on documentation from this point forward, right? They are tracking those as far as statistical purposes. And we know that our patient was a smoker, a former smoker, but he quit 30 years ago. Well, that is going to risk adjust, okay, a patient that had been a smoker. So that's something that we want to make sure we highlight. All right, now, why is the patient being seen? They may have been seen for this encounter for a reason that does not risk adjust, right? Maybe they have a bronchial infection. Doesn't matter, because there will be other things in the encounter that are chronic conditions that we can pull an abstract and code from, because this is a valid encounter that gives us a face-to-face visit with an approved provider. And we want to get every chronic condition that we can possibly get from this documentation. And our patient is being seen for osteomyelitis. So now you need to ask yourself, does osteomyelitis risk adjust? Well, we'll look that up here in just a moment. So when you're doing this, you'd have either a little notepad or whatever you're doing this with. You have another, usually have two screens. So you have your documentation on one, and the other one you're putting in the information and making yourself notes. So we're going to write osteomyelitis, and we'll check and see if that risk adjusts. Remember, when you do risk adjustment for CMS, only chronic conditions risk adjust. If you're doing risk adjustment for HHS, then there may be things that risk adjust that don't seem to be chronic. So pay very close attention to the different codes and if they carry an HCC or not. All right, so now we're down to the HPI. We're going to be able to glean a lot of information from the HPI. And again, usually I kind of do this backwards. I verify my date. I verify that I've got a provider. It's the valid patient, the patient that I'm supposed to be doing the risk adjustment for, and their date of birth. Then I go down and look at the electronic signature. And then next I usually look at the list of diagnoses in the plan of care, because that gives me an idea of what I need to look at. But I'm doing it in another way for you, because I want you to see what should pop out when you just scan the document itself. Okay, so it's like I don't want to give you a heads up to what all we're going to be able to glean. We're going to kind of do it backwards from if you were doing it real world. So now we know we've got a smoker, and that's going to risk adjust. Osteomyelitis, we have to ask ourselves, is that going to risk adjust? We have a 65-year-old. So this is, I'm already going to tell you, this is a CMS case. So only the chronic conditions for CMS, not HHS. It's a 65-year-old man with PVD. Well, you have to know what PVD is, and that stands for peripheral vascular disease. Yes, that risk adjust. Great. You know, then we can bang, we got another thing. So now we got smoking and PVD, and then we got to check on osteomyelitis. And they have a right foot infected ulcer. Oh, that's really exciting, because do foot ulcers risk adjust? No. But if it's a patient with PVD that has an ulcer of the foot, that changes things. And it says the patient he has an infected ulcer and osteomyelitis, which is just an infection of the muscle and going down into the bone and stuff. It's a very serious thing. Status post, okay, that's what that means, is S/P, status post RLE stenting. What do you think RLE stands for? So go ahead, and if you know what RLE stands for, put it in the chat. Let's look at that. And a TMA. TMA, so status post, RLE stenting, and TMA. I can see you guys are sending me notes, so I was like, good, 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 good. All right. Had 6 weeks of IV antibiotics. That is a long time to have IV antibiotics. Just so you know, osteomyelitis is a big deal. It is a dangerous infection. It's very likely that it could turn septic and kill you. So, and the fact that the patient has PVD, they have poor circulation to begin with. Let's see, the IV antibiotics were finished on 8/11. So now we're on 8/13. So just a few days ago, they finished the antibiotics, IV antibiotic. And so now we're going to, that's why they're doing this follow-up. Foot is casted, okay, feels well, no pain in foot or leg. Excellent, excellent prognosis. So what have we got so far? Reiterate, we got a smoker, we have PVD, we have a right foot ulcer, we have osteomyelitis, and we've got a TMA. Okay, so do you know, anybody else figured out what TMA means yet? I'm not seeing anybody that's got TMA. Okay, let's go down a little bit more. I was hoping that, you know, but RLE, very good. Stephanie, Whitney, you guys are on the ball. Right lower extremity, RLE. Right lower extremity. Left lower extremity would be LLE, right? Right upper extremity would be RUE in the same way. Whitney, got it. First one that I'm seeing. Congratulations. Gold star to Whitney. Transmetatarsal amputation. Very good. Now, Megan, she did something that, yes, also is a TMA, but it doesn't go with an RLE. So she put thrombotic microangiopathy. Very good. Very good. But no, not the right one. Good guess, though, Megan. Appreciate that. All right. So what have we got now? We know, again, smoker, right? PVD, osteomyelitis, ulcer, and now we have a amputation. A tarsal amputation means they had a toe taken off. That's your tarsals, your metatarsals or your toes. I'm always telling you, you got to know the bones. If you know the bones, it'll make you, everything else is named off the bone. So, you know, this is good stuff, really good stuff. So another reason this is a fabulous encounter to look at is because we're increasing your knowledge, right? The verbiage and stuff. This is so exciting. All right. Now you can tell I'm getting excited. Yes. Now let's look at the medications, because one of the things that's very important to know is that we have to have a line showing that these diagnoses that we are going to collect an HCC on are current chronic conditions, right? So we have to be able to draw a line. And plus the med list is going to give us some valuable information as to if there are any other chronic conditions that we should have a red flag on, because this patient could have been coming in for an upper respiratory infection. But if you look at their med list and you can, and that it is mentioned that they have something that risk adjusts, and then you can verify that in the documentation, you get to collect it. And so usually that's another reason I really like risk adjustment. You know, you're not coding just for the reason that they were there. Wow, what a fabulous med list. Very first thing, look, Lantus, they get 35 units. Wow, every morning. That's a lot. And they're getting Humalog, 15 units every evening, or AC with meals. So they're taking a lot of insulin. If they're taking insulin, what does that mean? They're diabetic. All right. That means we get to collect that. We just have to have them mention that they're diabetic, right? Just because it's on the med list, we can't grab it. Okay, we can't code off the med list, but we can use the med list to give us that line that we need to prove that the patient is currently has this condition. So are they a type 2 diabetic, or are they a type 1 diabetic? Now, another red flag should go up in your coding spidey senses, and there should be flapping around like, yay, look at this. If a patient has diabetes and they have PVD, what does that tell you? That's a different code than just your regular type 2 E11.9, right? They actually have a vascular disease, a complication. So it's not going to be your regular standard run-of-the-mill diabetic code. That gives you a higher risk adjustment score. And on top of that, we have a foot ulcer on a diabetic that has PVD. Oh my word, this is HCC gold, right? Oh, wow. So we're going to get to use some really fun codes now as we paint the picture for what's going on for this guy. Osteomyelitis itself, like I mentioned before, is a big bad infection. This is not something that you want, all right? It's scary to get this. It is treatable, but this guy was on 6 weeks of IV antibiotics. That's how it's treatable, right? This isn't just go to the urgent care and get an antibiotic. No, this is a bone and muscle infection. All right, so now that we know we got a diabetic, now I'm not going to list off what I already did because I've already said it several times, and we have to be careful because we haven't anywhere in the HPI. It didn't say he was diabetic, so we got to find that somewhere, or we can't code it. Flomax, okay, that's good. Aspirin is often given for people that have coronary issues or PVD because aspirin thins the blood, or if they have a cardiac issue. Plavix tells us that the patient probably has cholesterol issues. And then we got Magox, Percocet for pain, because honestly, osteomyelitis is also very painful. Norvasc, do you know what Norvasc is? Lisinopril, also conditions risk adjust with lisinopril. Labatol, multiple vitamin, cinalaxative and Colace. Cinalax and Colace are for him being constipated. So again, we've got some possibilities here that are going to allow us to risk adjust. And if they don't allow us to get a regular HCC, we may be able to collect an RX HCC. But we have to be able to, it has to be documented or we can't pull it. NKDA. Does anybody know what NKDA stands for? Put it in the chat. Let's see what you got in there. NKDA. Stephanie was first. Congratulations. No known drug allergies. Absolutely. Right. And you can, you may also see it documented as NKA, no known allergies, but there is a difference between no known allergies and no known drug allergies, right? So, but usually if it says no known allergies, this means drugs and everything. But if it's no known drug allergies, then we don't know that the patient isn't allergic to strawberries, right? Because it says there's no drug allergies that they know. So now we're getting into the medical problems. This is what the patient is complaining of, or problems that the patient has. They have a headache, right? Now we're saying these are the regular things that the patient's suffering from. Headache, that doesn't risk adjust. Everybody can have a headache, right? That isn't, even if it's chronic, it's not going to risk adjust. High blood pressure, which is hypertension. Ding, 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 that has an RX HCC, and they are on aspirin and they are on lisinopril. So we get to collect that, right? Now we have a diagnosis. First one that we get to validate. Then we've got shortness of breath with exercise. Okay, well, that would explain the Flomax. Heartburn, doesn't risk adjust. GERD risk adjusts, and Barrett's esophagus risk adjusts, but just plain old heartburn does not risk adjust. Kidney problems. Well, there are kidney problems that risk adjust, but just stating kidney problems is not enough. Okay, your UTI, urinary tract infection, does not risk adjust. Kidney stones don't risk adjust. Okay, so we've got to have more information than that. But a little heads up, when you're doing risk adjustment, that means you're going to be looking at a year's worth of documentation. If you know that this patient has kidney problems and they've had UTIs in the past, that means that your brain should be telling yourself, is this patient going to have chronic kidney disease in the future? You may, 3 months down the line, they may be diagnosed with CKD3. So again, when you're reading this, your brain is projecting, because a couple pages over and you've got something that wasn't mentioned or was mentioned, and now we can grab that diagnosis. Okay, that's what's different in risk adjustment versus pro-fee coding or other types of coding. Here we got our diagnosis: diabetes type 2. Yay! So if that's all it was, it would be E11.9, right? That's type 2 diabetic. Now, can a type 2 diabetic be on insulin? Absolutely, a type 2 diabetic can be on insulin. Can a type 1 diabetic not take insulin? No. A type 1 diabetic has to take insulin. That's one of the things that makes them different. Okay, so we know that our diabetic patients on some heavy, high doses of 2 different types of insulin, which is very common to have 2 different types, but they're taking a pretty hefty dose, okay? And then it states negative for diabetes type 1. Now, why would they say that? The reason they would say that is that there are some types of diabetes that we don't have a code for, but diabetes 1.5, which you may or may not have heard of, that will be like type 2 diabetes, but like within 15 years it turns into type 1. And so that's a specific type and everything. But if you were recently diagnosed with diabetes, and it doesn't matter what age you're at, they will test you to make sure that, to see if you're test type 1 or type 2. Okay. That's why they got away from the terminology juvenile diabetes, which is type 1 diabetes, because you usually found it when a person was a child, because type 1 diabetes is congenital. You're born with it, and you're going to have complications early in life. Is it possible for it not to show up? Yes, there are times when it has not shown up and they've gotten a type 1 diabetic diagnosis. But again, that is more rare. So you may see documentation, and keep in mind too, this is a real encounter. This is the only thing redacted out of this was the patient's name and personal documentation, and the provider's names were changed and everything. So again, this is exactly the documentation that the provider put down for us. So do we have any more? Nope. Now we're getting back. Surgeries, hospitalizations, none was mentioned. So we'll keep going. Now, another thing about risk adjustment, when you go from one page to another, the patient's name and date of birth has to be on every page. Okay. Now, some companies may say, well, you don't have to have the date of birth, but you definitely have to have the patient's name on every page, or you have to have the date of service. So again, different different companies will have different rules, right? So for ours, we had to have the patient's name, date of service, and date of birth on every page. So, but just because this doesn't have the date of service and has the date of birth, you know, we're okay. We're not going to scrutinize that. All right. So review of systems. Now we could pull in more chronic conditions off of this. So this is a very pertinent place to look. Constitution denies anorexia, chills, rigors, fever, night sweats, and weight loss. Okay, that's all good. That doesn't really tell us anything. Cardiovascular system denies any chest pains, lightheadedness, or syncope, which means they aren't fainting. GI. The intestinal tract, gastrointestinal, denies abdominal pain, abdominal swelling, constipation, diarrhea, hematemesis, which is blood in your stools, hematochezia, and nausea and vomiting. Doesn't have anything. Okay, good. Musculoskeletal denies arthralgias, leg swelling, malaise, and pain. Okay, if you don't know what those words are, look them up. But malaise, it would be malaise and fatigue, feeling like, you know. Skin denies pruritus, rash, redness, or ulcers. Well, any different ulcers, but we know we have a foot ulcer. So it's like, wait, denies ulcer. We got an ulcer on the foot. But anyway, endocrine, which is going to be anything that has to do with diabetes, denies decreased energy, intolerance to cold, intolerance to heat, polydipsia, or polyuria. Okay, no problem. Hematological and lymphatic system, meaning the blood in the lymph system, denies in easy bleeding, easy bruising, and enlarged lymph nodes. Okay, now, why would they ask about that? Because the patient has PVD and they're on aspirin therapy, which is a blood thinner therapy. All right, these right here is very important to note, because you can pull documentation off here like a BMI if it risk adjusts. Now, the only time you can pull for risk adjustment, I'm not talking about pro-fee coding, risk adjustment, is if the BMI is very low or very high, right? And I can't remember, it's 40 or 45 above that for a BMI will risk adjust, and I think it's under 30 or 28. I think it's 28. You'll have to look and verify that, but just know that you could pull a BMI to risk adjust. Now, if you were doing pro-fee coding, you could code for a BMI that was abnormal, but you have to still have them, the provider has to state that the patient is obese, all right, or underweight, one or the other. Okay, so now we're getting into the exam. Maybe really this didn't give us anything, right? The review systems didn't really give us anything, but note that the patient's in the wheelchair, okay? And often you may see this right here with the vitals and stuff, is you will find here that often if a person has an amputation, it's noted below the knee amputation. All it'll say is BKA, below the knee amputation, or something like that. And that's a risk adjustment HCC that's often not seen. Okay, exam. Constitution appears healthy and well developed, no acute sign of distress present. Ding ding. Oral pharynx, no arrhythmia, exudate, thrush, or ulcers, great. ENT looks good. Neck, normal, no masses, great. Respiration. Now, look here, respirations are regular and unlabored. We know that he had some shortness of breath. Are we going to get anything there? No, everything looks good. So we're good there. Cardiovascular rate is regular, rhythm is regular, SA is normal, S1 is normal, S2 is normal, no heart murmur appreciated, meaning he could hear there was no evidence of a heart murmur. A lot of times you'll see this as abbreviated normal R times 3, rate, rhythm, things like that. Extremities, no edema of the lower limbs bilaterally, right foot hard cast. Now we've got validation again, that line saying, hey, yeah, he's in a cast because he has osteomyelitis and he had an amputation to his foot. So that's fabulous. We have confirmation. We've got our line. Also, the fact that he checked the feet, the extremities, also can give you a line when people have diabetes. Abdomen, normal bowel sounds, everything's soft, non-tender, no guarding, rigidity, rebound, tenderness, no palpable hepatosplenomegaly, meaning the liver, which is hepto, and spleen, the spleen are not enlarged. Especially the spleen, when you have an infection, can get enlarged because it'll start producing a lot of white blood cells. Lymph nodes, no visible, palpable lymph nodes. So that's good, because when you have an infection, your lymph nodes they act up and start working. No rash, neuro effect is normal, memory is grossly intact. So meaning overall intact. So assessment, this is what our diagnosis is going to be. Osteomyelitis, chronic ankle and foot. So we have chronic osteomyelitis, ankle and foot. Very interesting. So what's the plan? Comments. Status post TMA. So he's had an amputation, revascularization, and 6 weeks IV antibiotics. Order written for Happyville for meaning that's the pharmacy, for Augmentin 500 milligrams twice a day to finish the course. So he's not going to get more the IV because it's status post IV for 6 weeks, and now we're going to give him Augmentin 500 milligrams twice a day to finish out and see if that doesn't, we don't want that to continue on. All right, now we get to look at the codes. We already looked at the electronic signature. We verified. We have, we know we definitely have the TMA, the amputation and stuff. So what do we get to code for? Yay! These are the codes that were pulled out. Now, I do have find a code up, but I think that these are pretty self-explanatory. I would like for you to take time to go and look at these codes individually in your manuals, all right? Because that's going to help you whether you're practicing for risk adjustment or just pro-fee. Right, you need to be familiar that these codes exist and the verbiage that's associated with them. So the first thing, type 2 diabetes mellitus with diabetic peripheral angiopathy without gangrene. So gangrene is not the same as osteomyelitis. Can a person have osteomyelitis and gangrene? Absolutely they can, right? But gangrene is an infection that causes death of tissue, right? That's something different than osteomyelitis. Osteomyelitis is an infection of the bone and the muscle. Okay, you usually don't get infection down to the muscle and to the bone. Okay, so we have a diabetic that has peripheral angiopathy, and that's our PVD. Right, we got that verified. E11.51. Then we also get to code the foot ulcer because we have a diabetic with a foot ulcer. And so that's going to be E11.621. Now, you stop and say, wait a minute, can you code more than one diabetic? Yeah, any type of complication that that is associated with diabetes, absolutely you get to code them. You could have somebody that has 3 or 4 diabetic codes, E11 codes. Now we've got a non-pressure chronic ulcer of other part of right foot with unspecified severity. Right now, you're saying, why do we get to code this L code, this ulcer, when we've already coded the patient as diabetic and has a foot ulcer? Because you're not coding the foot ulcer. You're stating in the E11 code, you're stating that we have a diabetic that has a complication and it's a foot ulcer. And that tells a story, because that once a diabetic gets a foot ulcer, their care changes, right? So you also then have to identify what type of foot ulcer is it. It's not just a diabetic foot ulcer. What is it? And so that's an L97.591, excuse me, 519. I inverted those. Now we have other complications. We have E11.69, type 2 diabetic with other specified complications. What does that mean? That means we have a diabetic that has gotten additional complications that there isn't a specific code for, and that would be the osteomyelitis. Okay, then we get to code the osteomyelitis, which is going to be M86.671, other chronic osteomyelitis, right ankle and foot. Now, the last part of that code tells you whether it's right or left and what part of the body. You can get osteomyelitis wherever you have a bone or a muscle. Okay, so then now wrapping up the other codes, we have a type 2 diabetic that's on insulin. They're on long-term insulin, which is Z79.4. This all risk adjusts. You want to make sure you capture that, because if you don't, you're missing an HCC. That HCC is different than the diabetic HCC you get for the PVD and the foot ulcer and the complications. Those are 19s. Long-term insulin use is an 18. So now we get to collect an HCC of 18 and 19. Right, so that's very important. Let's see, acquired absence of other right toe, Z89.421. Because they had an amputation, which is an acquired absence of a limb or toe. Then we have essential hypertension, I-10, and personal history of nicotine use, Z87.891. Now remember, we're pretty sure that this guy had cholesterol problems because he's taking Plavix. However, nowhere in the documentation was it listed that the person had any cholesterol problems, so we can't collect that. You know, we had it in the med list, but it wasn't listed anywhere else, so we're kind of stuck with that. Right, now, before I look at your questions, because I do see them, and we'll go over them, let's look at this fabulous rationale that Tiffany wrote out for us. And this is the way we are going to do all of these case studies. We're going to tell you how to look them up and also why they are pertinent, right? So for the most part, I'm going to read this and highlight and pause and stop on some of this. Normally, I don't just read things, but I want you to get a feel for how our rationales are set up and the standard at which we want to hold all of our rationales to. There sometimes you'll do case studies or you'll see them and you get down to the end and you're like, well, okay, you say this is what we have to code, but you didn't tell me why, you know, or even how to find it. So again, we're going to work very hard to make our rationales even better than they were before. And I have to tell you, we have fabulous rationales to begin with. Okay, so the rationale starting here is going to be that it's necessary to report diabetes with any code as necessary to completely report a patient's condition. That's why you have more than one diabetic code. They are not just a type 2 diabetic. They are a type 2 diabetic that takes insulin. They are a type 2 diabetic that has a foot ulcer. They are a type 2 diabetic that has PVD, right? So again, that tells a lot of the story. Why do we have to list all those? Because if you have a patient that has all of those chronic things happening within their diabetes now, next year it could be even worse. And so all of this is retrospective with risk adjustment. If we don't document and pull out the HCCs that risk adjust now, they're not going to set enough money aside for Medicare for this patient next year. If you've had osteomyelitis and already had a foot ulcer and you have PVD, it would be fabulous if this patient maintained their diabetes and everything was all honky-dory for another year, but chances are it's not going to be. So we have to have enough money set aside. Plus, statistically, we need to see how much does it cost to treat a patient, on average when they have these comorbidities. All right, so she refers to the guidelines and why you would need to code the specific PVD, and that the guidelines state that if there's a code for it, then it's associated. So a patient can have diabetes. In the past, we would have said a patient can have diabetes and PVD and it not be related. Okay, so you would code E11.9 and then the PVD code. But that changed in the coding guidelines. Now, if there is a list below the diabetes that a patient could have something, and PVD is one of them, then you just automatically assume there's a causal relationship between them. Okay, that's a relatively new guideline, kind of turned everything on its head. So you will code diabetic PVD. Okay, that goes with anything else that's in that drop down in your index. So we have the PVD reported, and she explains how to do that. That we're going to use the 0.51, the foot ulcer, how it's found, and it says use additional code to identify the site of ulcer. So that gave you the reason to code L97.519. Osteomyelitis is reported with that complication code with diabetes, because there isn't a code for a patient that has osteomyelitis and diabetes, but it definitely is related because it's from the ulcer. Okay, and then we get into the, let's see, M86.671 that tells you, hey, if there's a complication, additional code, you need to code from the musculoskeletal system. So that's done. The insulin, not only now do we have long-term insulin use, we also have long-term oral glucose medication. So there's an additional code for that. That's a Z79 code. Pay attention to that. That's a relatively new thing as well. Then let's see. Oh, here, she even put it in there for you. How awesome is that? The Z79.84. And then Lantus and Humalog was our insulin. The patient is status post transmetatarsal amputation, which is going to give us the Z89.421. Hypertension does risk adjust with an RX HCC. It doesn't carry a standard HCC, but you want to collect it, because when a patient has hypertension, which is a chronic condition, that affects the entire body, not just the cardiovascular system. It definitely affects the kidneys. Now, we already have a heads up that the patient has kidney issues, right? So we can expect, if they have kidney issues and hypertension, CKD is down the road for this patient most likely, because also diabetes affects hypertension and the kidneys. So you got several whammies here for this patient. Pay attention to the different AMA plans and policies and procedures, because again, there are some things they may say, hey, I don't want you to collect any RX HCCs. We're only collecting straight HCCs. And then they say, okay, now we are collecting RX HCCs. So that means that you would or would not collect hypertension and things like hyperlipidemia. Those things don't risk adjust for HCCs. RX HCCs means they're chronic conditions, but they're treated with a medication, right? Nothing more than that. And then we get to code that the patient is a smoker. The Z87.891 because they were two of the 2-pack a day history of smoking dependence. And there you go. So now let's look at these questions real quick, because there were some great ones. Let me just go back. It says, I have seen some patients who take 20 to 27 medications. I've also seen quite a few patients lately who have had a BKA, below the knee amputation. Very good. You've got to be aware of that, because those slip through and they carry a heavy HCC. Why would they do that? Why would that be a chronic condition? First of all, they're not going to grow their leg back. But when a person has an amputation of an extremity, they're not usually as active, especially if they're a Medicare patient. They're and let's say they are relatively active and they have a prosthetic, but they have a prosthetic that rubs on their leg, their stump. And so they always are prone to having ulcerations and skin integrity problems. And then you throw in one that has diabetes as well. So do not miss the above the knee amputations and the below the knee amputations, BKA. A migraine does not risk adjust. No, I'm almost positive a migraine does not risk adjust, not even a chronic migraine, and that is a condition. Let's see. Oh, I would think chronic kidney disease would risk adjust. Yes, CKD3 and up do risk adjust. If a patient's diabetic, then you get to use the diabetic code for the diabetes with renal manifestations, and then you code the N18.3 for CKD3, and then so yes, and hypertension plays a big part in CKD. And then you can have hypertensive heart disease and that go along with the CKD too. And this patient, quite honestly, is heading towards CKD probably. You know, it's just probably. First of all, a lot of times the medication, especially IV medications and things, for you have to filter that through your body, through your kidneys. So that compromises. Not only does diabetes compromise the kidneys and hypertension compromises, but now we've got, you know, an infection compromising it as well. Oh, and Whitney would like to do an OB case study. Hey, we can definitely do that. We'll go pull one out, and maybe you can send that into the topics request, and we'll do one in the club scenario, because there's some really good ones out there. We did get a really large supply of both outpatient and inpatient charts, and so as we weed through these, we are going to be able to take this particular chart, Mr. Billy Blue. You'll see him again in a pro-fee, not looking at risk adjustment, but for pro-fee, which is different, right? Because we're not coding for the chronic conditions, but why the patient was being seen. And then we are going to look at it with an auditor's eye as well. So, and with pro-fee, we'd be doing CPT. So, you know, what's the E&M going to be on this? We didn't do a procedure. We definitely get an E&M. Is it going to be a 99214 or a 99215? It's definitely not going to be below that. And then why it would be one or the other. And so an auditing looking, we can also look at it from a compliance issue. You know, is there any documentation compliance-wise that this isn't set up that we could change to make this better documentation? So there we go. Very good. And I think, any other questions before we move to this is really the last of it, but oh, let me click on that again. It didn't want to click. There was the diagnosis codes. Just went ahead and copy and pasted those there for you so that you can have a better idea of the ones that we look at. And again, as I mentioned before, what I'd like for you to do is to go and look up each one of these codes and read the descriptions, read the guidelines surrounding them, and see if there's something that you weren't aware of, maybe an aha moment. You know, so that'll make you, just being aware will make you a better coder. And then would quit smoking 3 days ago be considered a history or not? Well, it just really depends if your provider says it is or isn't. So I would query the provider if he considers that a history of smoking or not. 3 days. You know, because it's up to him. Quite honestly, I would say no. In my humble opinion, I would think, oh, that's pretty unlikely. 3 days, but that's good. but if they're actively being treated for the cessation of smoking, maybe they're on Chantix or something else, and they haven't smoked for 3 days, then it's not a history because they're being treated for it. So that might be a heads up. But if they said, yeah, I quit 3 days ago, let the provider say if that's a history or not. But again, if they're being treated for it, then it's not. Any other questions? Okay, so here is some resources that, of course, we had our CCO case study project. Tiffany, great intern, worked on those. And then I pulled some knowledge that I gained from Ignacia August from the DC conference, regional conference. Fabulous. I went and looked at her her notes and stuff several times. Loved sitting in that particular lecture. And so happy to give her attribution and share that with you. All right. Let's see. Oh, we got, although the doctor doesn't directly document the diabetes correlated, we can code that correlation. Yes, you can. That is a new guideline that came in, was it last year or the year before? The years kind of run around to me. It wasn't like that before, but if a patient has, for example, diabetes and CKD, then they have diabetes with renal complications because it is an option. And quite honestly, so it is a causal relationship. Before, they would say you had to have, the provider had to document the correlation, and they would say diabetes E11.9 and CKD in 18.4, which is CKD4. You would code them separately, but now you would code E11 point, and I cannot remember which one's the diabetic renal complication. I can't remember if it's a 3 or 0.3 or 4. I can't remember. But then you would code in 18.4 as well. Because the guidelines tell you what is the renal complication. So yes, you do. Mm-hmm. And would you also code CHF complication? Yes, you would. A congestive heart failure is definitely a one. Yeah. So read all of the complications that come with diabetes. Be very familiar with those, and maybe even make some notes if you need to in that. Thanks, Whitney. E11.29 is renal complications. I kept thinking it's a 3 or a 4. I kept thinking it could be a 2, right? No, it's. I guess you could remember it because if you have to go number 1 or number 2, then that, if you have to potty, that's renal. Whatever it takes to remember, right? That's all that matters. Okay, guys, that is it. Don't forget, go post your questions in the CCO Club. If you're joining us and you're not part of the CCO Club, maybe you're on YouTube or Facebook, don't forget to like and subscribe. But go check out the CCO Club. It is cco.us. That's where we get the questions and the ideas and the conversations and the people that I've been seeing over here out of the corner of my eye. There are people that are in the CCO Club. And so we get to communicate more readily. We definitely give them priority to answer questions and stuff. And great group of people that are in there, a lot of subject matter experts, our instructors, our coaches, and former students, current students, and SMEs, subject matter experts, SMEs. So thank you, guys. That's it. See you next time.